18 participants on the call. It's just a minute past 5. Maybe I will just crave your indulgence. The moment is exactly 5 minutes past 5. We'll kickstart this meeting. So just bear with us. Let's allow others to join. So in the next 3 minutes, exactly 5 minutes past 5, we'll kickstart this webinar. Once again, you're welcome. Happy weekend to everyone. And I expect that we'll be richer in knowledge and the experiences we share after this presentation. So please, let's just keep 2 more minutes or 3 minutes. The moment it's 5 minutes past 5, we'll start this webinar. Thank you and welcome once again. Thank you. Once again, this meeting starts at exactly 5 minutes past 5. So please just hold on. Just 5 minutes past 5, we'll start the meeting. Thank you for joining. Okay, once again, good evening, everyone. You're welcome to this webinar organized by the Endocrine and the Metabolism Society of Nigeria, the South-South Zone. We're reaching you specifically from Uyo, Akwa Ibom State. Today, we're bringing you a very interesting topic, diabetes insipidus, which we've christened the hidden drought. You get to know why we described it as a hidden drought and because of this presentation. The presenter for today is a senior resident in the Department of Internal Medicine of the University of Uyo Teaching Hospital. His name is Dr. Asupong Esson. He'll be taking us around the world of diabetes insipidus, and we're expecting to take a maximum of 40 minutes. But I'm sure he can do this in less than 40 minutes. While he's presenting, we expect the listeners to take down your comments, your contributions, your questions, put it down in the chat box so that we can make reference to it after the presentation. If you wish to speak after the presentation, please do well by raising your hand and you'll be acknowledged to speak. After the presentation, I'll give a brief roundup, and then the president of the association will give the final overview. So without wasting much time, we'll invite the presenter, Dr. Asupong Esor to take the floor. Dr. Esor, please.
Thank you, Dr. Onu. Good evening, my professors, teachers. Let me especially greet the national executives of EMSON, the South-South executives, my teachers and colleagues. Good evening and welcome. My name is Asupong Esor. I'm a senior registrar in the Endocrine Metabolism and Diabetes Unit, University of Uyo Teaching Hospital. This evening, we'll be presenting the hidden drought, uncovering the mystery of diabetes insipidus. I hope I'm audible. And we're going to do so under this outline. By way of introduction, diabetes insipidus literally means the excretion of large volumes of urine, usually that is hypotonic, dilute, and tasteless. So remember, the Greek word for diabetes means to siphon. It also means to pass through. Insipidus, on the other hand, means tasteless, to lack zest, to lack flavor. Hence, putting the two words together, diabetes insipidus just means passing large volumes of urine that is tasteless and lacks zest. More scientifically, diabetes insipidus is an endocrine condition involving the posterior pituitary peptide hormone, antidiuretic hormone, otherwise known as arginine vasopressin. It's defined clinically by the passage of large volumes of urine of up greater than 3 liters in 24 hours, and usually with osmolality, urine osmolality of less than 200 milliosmoles per kg. So diabetes insipidus is marked by craving for water resultant from extreme thirst and resultant from passing excessive quantities of highly dilute urine. How is diabetes insipidus classified? Two major classifications are known. One is central diabetes insipidus, usually resultant from the absence or the deficiency of antidiuretic hormone. On the 1st of April in 2025, the International Society for Endocrinology released a press statement whereby central diabetes insipidus is being renamed formally to arginine vasopressor deficiency. Now, the reason for this is because this new name is a pointer to both the cause and gives direction to the treatment of the condition. So in the course of this presentation, I would repeatedly refer to central diabetes insipidus as arginine vasopressor deficiency. The second main classification is nephrogenic diabetes insipidus. Usually, this is resultant or characterized by resistance of the terminal convoluting tubules and the collecting duct to the action of antidiuretic hormone. The other forms of diabetes insipidus that have been described, such as the gestational diabetes insipidus and primary polydipsia. In gestational diabetes insipidus, there is degradation of vasopressin, usually by a placental vasopressinase or an oxytocinase. The primary polydipsia, also known as dipsogenic diabetes insipidus, usually seen as a mental health disorder, is usually resultant from a primary defect in the regulation of thirst. Epidemiologically, this condition is uncommon and affects about 1 in 25,000 people globally. Where prevalence is taken very seriously in the US, prevalence is 3 cases per 100,000 population. And it is known that diabetes insipidus does not show any age predilection, sex predilection, and it can occur at any stage of life. And it does not show any significant prevalence amongst ethnic groups, and there's no such documentation. So when mutations occur from the aquaporin 2, where there is a mutation with aquaporin 2, the incidence is found to be about 1 in 20 million deaths. And this is usually for nephrogenic diabetes insipidus. In Nigeria, the prevalence is not documented. However, some researchers have written case reports and have published them as follows. In 2014, in University of Port Harcourt Teaching Hospital, A.N. Opere et al. Published a paper on a case of central diabetes insipidus in a female toddler. In 2022, Halado et al. Published a case involving 3 subjects from the teaching hospital in Katsina in northern Nigeria. What is the etiopathogenesis of diabetes insipidus? Let's start with the central diabetes insipidus. This can be resultant from genetic abnormalities of the neurohypophyseal neurons. In this case, the condition can be resultant from familial hypothalamic diabetes insipidus. There could be pathologic lesions of the neurohypophysis. When we discuss the pathophysiology, it will be clearer to us. So when there are pathologic lesions of the neurohypophysis, this condition can result, and this is very common in craniopharyngiomas. And they could also be resultant from metastatic disease to the pituitary hypothalamic area. In trauma to the brain or following surgery, there could be trauma to the posterior stalk, and this could result in central diabetes insipidus. Patients that have closed head trauma, especially where there's fracture of the basal of the skull, this can also result. In infiltrative and granulomatous conditions, such as sarcoidosis, tuberculosis, Wegener's granulomatosis, central diabetes insipidus can also occur, especially when the infiltration involves the posterior stalk. It can be resultant from lymphocytic infundibular hypophysitis, where there is cerebral anoxia, vascular lesions, such as in AV malformations, Sheehan syndrome, aneurysms, where there's aortic coronary bypass. Diabetes insipidus, especially the central type, could occur. What is the etiology in nephrogenic diabetes insipidus? Congenital cases can occur X-linked recessive mutation of the V2 receptor. We're going to see shortly what the V2 receptor does. Autosomal recessive mutation of aquaporin 2 water channels. These constitute the congenital nephrogenic diabetes insipidus. In some cases, etiology could be from decreased end organ response to vasopressin, from any other etiology unknown. Gestational diabetes, in this case, there's increased metabolism of vasopressin in pregnancy. For the acquired nephrogenic diabetes insipidus, this is usually from medications, direct injury to the aquaporin channels, and downregulation, usually occurring in medications such as lithium. Lithium is most implicated. Amphotericin B, foscarnet, or fluoxacin, orlistat, amongst others, have been implicated. But the highest frequency has been found with use of lithium, especially in patients that have bipolar affective disorder. Patients with hypercalcemia, hypokalemia can present with acquired nephrogenic diabetes insipidus. It's very, very important to mention that patients with osmotic diuresis from hyperglycemia could also present with this. This is why it's very important to have a higher index of suspicion and screen patients. Renal disease, whether from sickle cell nephropathy or amyloidosis, can be an etiological factors in acquired nephrogenic diabetes insipidus. Under the pathophysiology, it's important to remember that water balance is key in humans. And water balance is usually accomplished by way of test, antidiuretic hormone action. The kidneys are very important, and a substance called apelin. Apelin is a counter substance that is produced in the posterior pituitary that counters the effect of antidiuretic hormone. These 4 factors are key to water balance in humans, and they play crucial roles in the pathophysiology of diabetes insipidus. So diabetes insipidus, as we have been told, is resultant primarily from the absence, deficiency, or resistance to the action of antidiuretic hormone. Recall that antidiuretic hormone is a nonapeptide that is produced in the supraventricular and paraventricular and supraoptic nuclei of the hypothalamus, and it's transported down the neuronal axon and stored in the posterior pituitary, where it is released. So it exerts its effect majorly on the distal convoluting tube, the collecting ducts, and the And it does this by upregulating aquaporin channels. Remember, aquaporin channels are usually produced and inserted into the collecting ducts to help passage of fluid to form urine. So it does this by altering the water permeability of the cortical and the medullary collecting tubules, and it does so by two principal receptors, one, V1 receptor and V2 receptor. It's important to state that the action of V1 is not clinically significant and is quite minimal. The V1 is known to mediate vasoconstriction, enhances corticotropin release, and also involved in renal prostaglandin synthesis. On the other hand, the V2 receptor mediates the main antidiuretic response, and this is where ADH exerts the majority of its effect. So at osmolarities below 285 milliosmoles per kg, ADH is normally suppressed. I'm talking of plasma osmolarity. And this, when it becomes progressive, can lead to a maximally dilute urine. Usually maximally dilute urine will be that with urine osmolarity less than 100 milliosmol per kg. However, when plasma osmolarity is above 285 milliosmoles per kg, ADH secretion is noted to increase linearly with plasma osmolarity. And this has effect in the water deprivation testing that we'll be discussing subsequently. So the summary of the pathophysiologic mechanisms are majorly as follows. One, there's abnormal decreased synthesis or secretion of vasopressin. There is increased metabolism of vasopressin as occurs like in gestational diabetes insipidus, or end organ response to vasopressin. So when vasopressin is reduced or it's absent, as in central diabetes insipidus, the antidiuretic activity at the usual site of ADH becomes non-existent. So there is abnormal excretion of large volumes of dilute urine. So when this occurs, there will be plasma hyperosmolarity. And this will usually yield an apparent increase in serum sodium. So we are saying apparent increase because sodium will hover around the upper limit of normal or slightly above the upper limit of normal. So elevated serum sodium in a patient should raise our suspicion, especially those that have polyuria. So elevated plasma osmolarity will stimulate thirst, which will cause the patient to drink large volumes of fluid. This is in a bid to keep their
normal range. So again, the clinical presentation of central diabetes is that of polyuria of dilute urine, polydipsia, serum sodium that is elevated or in the high normal range. Now, I'm talking about nephrogenic diabetes insipidus. There is disruption of the
signaling system in the kidneys. So when this occurs, there will be downregulation of aquaporin 2 synthesis, and there will be protein abundance in the principal cells of the collecting duct. So there's also inactivating mutations that can occur in some etiologies. And when these inactivating mutations occur, the gene coding for the V2 receptors would result in insufficient generation of G protein stimulated cyclic AMP. Once this is deficient, the active insertion of aquaporin 2 channels into the apical membrane of the collecting duct becomes defective. So in some other circumstances, there is direct gene mutation of the aquaporin 2 channel. And this will also result in insufficient insertion of biologically active channels. Another pathophysiologic process that occurs in nephrogenic diabetes insipidus is that there's autophagy and dysfunction
metabolically induced etiologies. And this will usually affect the signaling pathway that involves glycogen synthetase kinase type 3, that's GSK3 beta. GSK3 is very important for collecting ducts to be maintained in their differentiated form. So once autophagy takes place,
that's from lithium or from metabolic etiologies, dysfunction will occur in these channels. However, it's important to state that the main mechanism that leads to progenitor diabetes insipidus is largely unknown. So the autophagy pathway or the autophagy theory is being proposed. In pregnancy, talking about the pathophysiology of gestational diabetes insipidus, it's important to remind that in normal pregnancy, total body water increases to as much as 7 to 8 liters. And this will result in widespread vasodilatation and usually mediated by the HCG and relaxin. Remember, HCG, human chorionic gonadotropin, is produced in pregnancy. So this volume is sensed as normal in pregnant people. And vasopressin will be produced or reduced around this increased volume. However, when it gets to the 20th to the 40th week of gestation, vasopressin metabolism is markedly increased. And in some circumstances, an aminopeptidase called oxytocinase or vasopressinase will be produced in some pregnant women. And this will significantly break down vasopressin, thus leading to inadequate amounts of vasopressin present for physiological or homeostatic function. Thus, not much will be present to prevent diuretic action. So patients will now develop gestational diabetes insipidus. So gestational diabetes insipidus usually resolves following delivery of the placenta, but in some patients, it may persist beyond 6 weeks of delivery. And these patients, just like in conventional in gestational diabetes mellitus, will need to be followed up subsequently. What are the clinical features of diabetes insipidus? Starting with central diabetes insipidus. For etiologies following trauma or surgery to the region of the posterior pituitary or hypothalamus, central diabetes insipidus exhibits one of 3 distinct patterns. It may exhibit transiency, just occurs for a short period of time and resolves. It may exhibit a pattern of permanence, and it may exhibit a triphasic pattern, which manifests usually as a polyuric phase, an antidiuretic phase, or occurs as permanent diabetes insipidus. Recall that it can occur as transient phase, a permanent pattern, or a triphasic pattern. Now, in the polyuric phase of the triphasic pattern, this usually lasts for about 4 to 5 days. This will be due to inhibition of the production of ADH, and this will result in increase in urine volume and concomitant fall in urinary osmolality. If it progresses to the antidiuretic phase, which usually lasts for 5 to 6 days, there will be release of stored antidiuretic hormone. So it tries to compensate. However, when stores of ADH are exhausted, the phase of permanence occurs. And here the cells that produce ADH are absent and unable to produce more. Again, in central diabetes insipidus following surgery, transiency could occur, permanency could occur, or it could manifest in a triphasic pattern that is usually phase or a presentation of diabetes insipidus in adults would be that of polyuria, highly variable, usually volumes between 30 to 20 liters in 24 hours. So somebody may say, 20 liters will be too much. But remember, in a patient where thirst regulation is intact, the patient will be consuming large volumes of water to compensate for the dehydration state. So polyuria of up to 20 liters is being documented and occurs. It could occur as nocturia, and there will be polydipsia. Now, when there is chronicity, usually patients become irritable, lethargic, weak. They have profound dehydration. They could manifest with muscular twitching, seizures, and even outright frank coma. In some patients, where they are able to hold urine in the bladder for a while, hydronephrosis could occur with pelvic fullness. There could be flank tenderness or pain that radiates to the genital area. So now, Following surgery or any other etiology where the anterior pituitary alongside the posterior pituitary is damaged, patients could present with features suggestive of anterior pituitary insufficiency, such as excessive fatigue, diminished libido, headaches, dry skin, hair loss, and the likes. Let's make some notes on diabetes insipidus in children. It's rare in children, but it still exists. But the more common form is the nephrogenic diabetes insipidus, and is usually the acquired form. Recall from the etiology, we had said that use of medications such as Orlistat, lithium, and the like could precipitate nephrogenic diabetes insipidus, the acquired type. So the signs and symptoms in children will vary with what the etiology is. If they are much younger children, it may be a genetic problem. If they are much older children, it may be an acquired problem. So it also varies with age of presentation, mode of onset. For instance, younger children may just have polyuria and excessive crying. Much older children may be with enuresis. So neonates and infants with nephrogenic diabetes insipidus are severely affected and can be difficult to treat. So enuresis may be the earliest manifestation, especially in older children. So children will always they'll make efforts to drink, increase fluid intake, but the urination will still occur. Other symptoms that could occur in children are that of failure to thrive, irritability. They could be excessive crying, growth retardation. They could present with weight loss. What are the investigations that should be done in evaluating for diabetes insipidus? First of all, that there is polyuria. So a 24-hour urinary collection should be done. Volume determination will usually be between 3 to 20 liters in a day. Recall, we had said that this electrolytemia, especially hypercalcemia, hypokalemia, could be an etiological factor. So serum electrolytes should be assayed. And the typical pattern in diabetes insipidus would be hypernatremia, a high normal serum sodium. Of course, plasma glucose levels should be assayed for, because diabetes mellitus could also present with polyuria. So plasma and urinary osmolality done concomitantly should be done. So the random plasma osmolality is generally greater than 285 milliosmol per kg, and typically urinary osmolality usually is less than 200 milliosmol per kg. But recall that we have said in very severe forms, osmolality could be as less as, urine osmolality could be as less as 100 milliosmoles per kg. Of course, urinary specific gravity should be determined. Patients will have hypostenuria with a specific gravity of less than 1.005. And this is a hallmark of diabetes insipidus. Now, the level of plasma antidiuretic hormone could be assayed directly. So if we find elevated plasma osmolality despite a relatively high basal level of ADH, this will suggest nephrogenic diabetes insipidus. Let me take that again, because you assay plasma ADH and you find that it is very, very high, but a patient is still having polyuria suggestive of diabetes insipidus. It means the posterior pituitary is actually secreting ADH, but the collecting ducts are insensitive to it. So this is a pointer to nephrogenic diabetes insipidus. So if you assay ADH and you find reduced levels or absence of ADH, is usually suggestive of cranial diabetes mellitus. And this is very important for us to do. So copeptin levels. Copeptin is a surrogate marker of ADH level. It's quite expensive to assay for and not usually done very routinely in clinical practice. But for research purposes, it is done. But direct assay of antidiuretic hormone is better. And it's also important to say that copeptin levels are slightly more physiologically stable to assay than ADH level. Let's talk about the water deprivation test, the Miller-Moses test. This is a semi-quantitative test to ensure adequate dehydration and maximal stimulation for ADH for diagnosis. It's usually performed for patients who have more chronic forms of diabetes insipidus. So the steps involves an initial 8 to 12 hour water deprivation, and subsequently there is administration of desmopressin. Desmopressin is a synthetic form of ADH that is produced. So this test is based on the measurement of urine osmolality to assess the renal action of ADH. So recall, dehydration will lead to an increase in plasma sodium concentration, which in turn will stimulate ADH release. Then the ADH will act on the kidneys, causing an increase in urine osmolality. So this is the principle. So if the stimulus for ADH is sufficient, usually for this Miller-Moses test, the urine osmolality should increase after water deprivation to more than 750 milliosmol per kg. So this is important in differentiating patients that have central diabetes insipidus from those that have nephrogenic diabetes insipidus. I'm going to explain a result chart for us. So what is a protocol for water deprivation test? Before this is done, it's important to discontinue certain medications that can contribute to polyuria, such as SGLT2 inhibitors, patients that are on diuretics, glucocorticoids, even patients that are taking desmopressin, patients taking NSAIDs and those taking caffeine should be discontinued. Once this is discontinued and patient is prepared and there's still significant polyuria, you can start the water deprivation test with close supervision. Obviously, baseline weight, heart rate, blood pressure, serum osmolality, serum sodium and urine osmolality should have been determined ab initio. So patients are kept on MPO and weight is monitored. Vital signs are also monitored. Urine output and osmolality is done at least every 2 hours. If you find 2 consecutive urine osmolalities that differ by less than 30 milliosmol per kg, or there is body weight loss of greater than 5% of the baseline weight that was taken, or patients present with orthostatic hypotension, please, it is important to discontinue this test. If not, the test is continued and 2 micrograms of desmopressin is administered, and subsequent serum sodium, urine osmolality, and serum osmolality is taken 1 or 2 hours after administration of desmopressin. How is Miller-Moses test interpreted? So for normal subjects, presumably like you and I, urine osmolality after deprivation should be about greater than 750 milliosmols per kg. After desmopressin is administered, the urine osmolality should still be greater than 750 milliosmol per kg. For patients that have central diabetes insipidus, recall that ADH is not present or deficient. So urine osmolality, patients will still be passing dilute urine even when water deprivation is on. So urine osmolality will be less than 300. Now, when you give what is not present in the patient, which is desmopressin, the urine osmolality will now jump to 750 milliosmol per kg after the statutory period. So this pattern is confirmatory for central diabetes insipidus. However, what is it that occurs in nephrogenic diabetes insipidus? Urine osmolality after water deprivation will be less than 300 milliosmol per kg. Recall, ADH is present, but it is ineffective at the collecting duct. So patients will still have polyuria of dilute urine. So even with water deprivation, it will still be less than 300 milliosmol per kg. When desmopressin is administered, there is still not an effect on the collecting duct because there is a defect there. So administration of desmopressin does not raise the urine osmolality. So it will still be less than 300 milliosmols per kg. So this confirms nephrogenic diabetes insipidus. In primary polydipsia, the urine osmolality after deprivation is usually variable between 300 to 750 milliosmol. Once it is given, that desmopressin is given, the urine osmolality will still be found to be less than 750 milliosmol per kg. All right, the same pattern is seen for partial diabetes insipidus. And remember, primary polydipsia and partial diabetes insipidus are close differentials of these other conditions. And remember, in primary polydipsia, there is a defect with test osmoregulation. All right, so what other investigations can be done? Brain magnetic resonance imaging can be done, and emphasis should be on the pituitary. So this may point to lesions of the pituitary or the hypothalamus, and this may be a pointer to the etiological factor. So we could also assay other anterior pituitary hormones, especially when the etiology is that of a traumatic brain injury. How do we treat diabetes insipidus? For the central diabetes insipidus, also termed adenine vasopressin deficiency, the main treatment option is to replace what is deficient. In this case, an ADH analog, desmopressin, is used. It's preferred in almost all patients. So physiological replacement with desmopressin has been found to be very effective. So desmopressin is a
and even in oral preparation, and can be administered 2 to 3 times per day, depending on the need of the patient. What is available readily in Nigeria is the 1-diamino 8D-arginine vasopressin, that's DDAVP. That's the desmopressin acetate. It is available in Nigeria, although expensive.
What is the flow chart for treatment? So do we think this patient has diabetes insipidus? If yes, what is the goal of therapy? First, let's control the symptoms. So thirst is controlled, polyuria will subsequently be controlled, and nocturia will be controlled. So you can do administration of desmopressin at bedtime. The dose for the oral formulation, initial therapy, usually 0.1 milligrams given at bedtime. Alternatively, it can be given as intranasal 2.5 micrograms through a meter dose spray, or given as desmopressin in the lyophilized form, that's given sublingually. Is nocturia controlled? If yes, you can go ahead and check whether daytime polyuria is controlled. If not, you can now increase the daytime dose of desmopressin, or you add adjunctive therapies that we're going to talk about, like the thiazide diuretics, or you give a low solute diet. What are the other treatment options that are available? Drugs, other medications can be given, such as carbamazepine, thiazide diuretics, non-steroidal anti-inflammatory medication. This can be used. Now, thiazide diuretics, which is most commonly used of all the medications, usually exhibits what is called a paradoxical effect. Remember, thiazide diuretics they act primarily at the distal convoluting tubule. However, in hypovolemia, they have an effect in the proximal convoluting tube. And what they do is they increase proximal sodium and water reabsorption. When they do this, they diminish the volume of water that reaches the collecting ducts, which are the ADH sensitive sites, and thus they reduce the urine output. So thiazide diuretics stand prime as an adjunct treatment in diabetes insipidus treatment. Now, for the non-steroidal anti-inflammatory drugs, remember that they are involved with inhibiting renal synthesis of prostaglandins, and prostaglandins are antagonists to ADH. So NSAIDs have been found to contribute significantly to treating patients that have diabetes insipidus. Of all the NSAIDs, indomethacin has been most recommended for use of treatment, even though it is not a common drug used in our clinical practice. But I know the neurologists use it in some kind of headaches. So indomethacin is recommended. And in normal subjects, pre-treatment with NSAIDs have been noticed to increase antidiuretic effect and amplifying the increase in urine osmolality by more than 200 milliosmoles per kg. We have already said that not all NSAIDs are effective. The most effective of all of them is indomethacin. The other treatment is with dietary modification. So patients can have a low solute diet, usually a low sodium and a low protein diet. This usually works effectively in combination with a thiazide diuretic. And patients will also have intravenous fluid replacement. In fact, one of the things that led to the advocacy for the change of name from central diabetes insipidus to arginine vasopressin deficiency was because of the case that occurred in the United Kingdom, where insufficient amount of fluid replacement was given to a patient, and patient kept having polyuria, and this diagnosis could not be made. So intravenous fluid replacement is very, very important. And recall, because of relative hypernatremia, fluid recommended is salt-poor intravenous fluid. Now, for the nephrogenic diabetes insipidus in adults, the main option of treatment is to look for what the underlying etiology is and make an attempt to correct it. So if it is from a medication such as lithium, you make effort at discontinuing the offending medication, or as much as possible, reduce the dose of the medication. However, it's important to state that in certain lithium-induced diseases, the damage done could be irreversible. And if this is irreversible, there is a remarkable deficiency with concentrating defect. That is a marked concentrating defect. So other underlying etiology should be sought for. Hypercalcemia should be corrected. Hypokalemia should be corrected where feasible. So in nephrogenic diabetes insipidus, after removing the etiologic agent, patients should also be given low sodium, low protein diet. So the reduction in urine output will be directly proportional to the fall in solute excretion. All right, patient compliance is also key here. So we also have a role for thiazide diuretic in nephrogenic diabetes insipidus. Doses as high as 25 milligrams once daily or maximally 25 milligrams given twice a day is recommended, especially in those with persistent symptomatic polyuria despite giving a low solute diet. Now, amiloride has a grade 2B recommendation, and usually if urine output is insufficiently reduced, even with use of low solute diet, even with use of thiazide diuretic. Now, it finds its role to improve especially lithium-induced AVP resistance, in whom lithium has to be recommended. Now, there are some patients who their doses of lithium will not likely be totally removed, but can be reduced. In such patients, amiloride has a grade 1B recommendation for use alongside thiazide diuretics and low sodium diet. However, we must be cautious. For patients taking lithium, their sodium levels and the use of thiazides must be taken into consideration, because thiazides and amiloride may increase the level of plasma lithium. And so this could have a counter effect on the patient. So thus it's important to do serial measurement of lithium levels in patients whose doses have been decreased. How do we treat gestational diabetes insipidus? So conservative management is done with concomitant water intake and electrolyte monitoring. This is very, very important. This is very, very important. Patients should have continuous electrolyte monitoring in them and should continually have water intake as much as possible. So desmopressin is also recommended for use, and this is usually instituted where the conservative management is insufficient to control the polyuria. And desmopressin has been shown to show good fetal safety profile. Its use is individualized. It is much, much, much best individualized. However, there is caution to be taken. When using desmopressin, caution must be exercised because it can cause hypernatremia, not in the fetus now, but in the mother. So the role of electrolyte monitoring, especially sodium monitoring, stands very key. So for partial diabetes insipidus, the treatment aims to achieve symptom control, to prevent dehydration with fluid replacement, and also correct electrolyte. However, if it becomes a progressive event, desmopressin has a role, and thiazide diuretics can also be utilized. For primary polydipsia, remember, these patients have a compulsive drive towards drinking water. So how is it treated? Usually the treatment lies within the domain of the mental health physicians. Behavioral modification is important. This is done by counseling and by cognitive behavioral therapy. This stands as the mainstay of treatment. There are medications that have been found to be useful in this set of patients. Olanzapine reduces polyuria. Candesartan has also been found to reduce polyuria. Acetazolamide is used to help reduce sodium levels and to encourage bicarbonate reabsorption in the kidney. What is the prognosis for patients with diabetes insipidus? The outcomes for patients with diabetes insipidus are thought to be generally good. Deaths are very rare, provided the thirst regulation is intact and patient has the capacity to drink water. So restoration of renal function may occur with medication-induced diabetes insipidus following stoppage of the offending medication. This is very, very important for the acquired types or medication-induced type. In conclusion, when we're evaluating patients for polyuria, let us not forget that diabetes insipidus exists and we should have a high index of suspicion for it. Even though it is rare, it is important to look for it. Patients that are evaluated should have treatments instituted early enough. Osmolarity of urine and plasma should be used as tools for monitoring and evaluation. And where the offending etiology is found and where it can be withdrawn, this should be done. These are my references. I want to thank you for listening.
Wow. Thank you very much, Dr. Asupong Esor, for that excellent and brilliant presentation. Actually lost for words. You've done justice to the topic, and I must commend you. That was good. Dr. Esor is a senior resident in the Department of Internal Medicine, the University of Uyo Teaching Hospital. And as I said earlier, we're reaching you from Uyo, the capital city of Akwa Ibom State in South Nigeria. And this webinar is organized by the South Zone of the Endocrine and Metabolism Society of Nigeria. Once again, thank you very much, Dr. Esor. I want to thank everyone for joining. And this is how we move subsequently. I'm going to briefly just highlight a few things that Dr. Esor has just presented. I'll just highlight it briefly. After that, we take one or two questions from the chat box. After that, we'll recognize a few hands that are up. Then in rounding up, we'll listen to some of the teachers in the South Zone. I've seen Professor Edo is here, Professor Nachuku, and Professor China here. We'll listen to them. And then finally, the president of EMSON, Professor Oloko, I think I've seen his name, is on the call here. He will give the final overview and vote of thanks. So that is how we're going to progress. So, henceforth. Now, it's important for us to note that diabetes, the word diabetes, is not synonymous with diabetes mellitus. Diabetes mellitus is far commoner than diabetes insipidus. But that does not mean that the word diabetes is synonymous with diabetes mellitus, because it could also be diabetes insipidus, which is why we mustn't ignore any patient that presents with polyuria and polydipsia, and you screen the patient for diabetes mellitus, and it turns out that it is not diabetes mellitus. It could just be diabetes insipidus. That's why we brought this topic for discuss. Yes, if you ignore diabetes insipidus, it remains hidden. And if it remains hidden, the clinical progression could lead to a clinical drought. Hence, the other phrase that is used to describe it, which is known as the hidden drought, the hidden drought. Now, Dr. Esor has mentioned that we have basically two types of diabetes insipidus. We have the central type, which has recently been renamed as arginine desmopressin deficiency. And then we have the nephrogenic type, and these are basically the two types we have. But he has also mentioned that there are other types, the dipsogenic type, which is seen in patients who have primary polydipsia. And then we also have the gestational diabetes insipidus, which is seen in pregnancy. While explaining the pathophysiology for this, he mentioned that we could have the secretion from the placenta of oxytocinase and the vasopressinase. These lead to continuous degradation of ADH, leading to gestational diabetes insipidus. Now, the good thing about gestational diabetes insipidus, according to the presentation we just listened to, is that just like diabetes mellitus, it tends to resolve after pregnancy. But in a few patients, it could persist. And also, he mentioned that sometimes in the patients may actually require desmopressin as part of the treatment. He also mentioned that diabetes insipidus can also be seen in children. If you see a child with some enuresis, frequent enuresis, and you screen the child for diabetes mellitus and it's negative, you must also think about diabetes insipidus. Now, he mentioned the drug desmopressin, which is an analog of ADH. Now, desmopressin is key not only in the treatment, but also key in making the diagnosis of diabetes insipidus. And if you listen carefully, he talked about its use in making the diagnosis when he was describing the water deprivation test, which will help us to differentiate between the central type, nephrogenic type, the primary polydipsia, and the partial diabetes insipidus. And he has also mentioned, which is also, he said, the fact that desmopressin is expensive, but it's available. It's available. So meaning that if there's need for us to treat this condition, the drug for the treatment is available, though it is expensive. And that even makes me want to suggest maybe we should add this drug to our list of emergency drugs. We may not see it that way, but I think it's important because it could be life-saving. The prognosis is good. It's fair. It's not really, the mortality is not very high if it is diagnosed early and treatment instituted early. The prognosis is fair. So I think that summarizes what Dr. EMSON has just presented. Now the floor is open. I've seen one question here in the chat box. Yes, there's a question here. Good evening, my teachers. Thank you for the presentation. How do I differentiate between gestational diabetes mellitus and gestational diabetes insipidus clinically? Dr. So, are you there? That question is for you. How do you differentiate between gestational diabetes mellitus and gestational diabetes insipidus? I think this should be.
Thank you.
Yeah, go ahead.
Thank you, sir. And I've seen the question by Dr. Collins Chikereze. Dr. Collins, so the key word here you are asking on is clinically. You can never be wrong with a good history. A good history should be able to point to you the etiology of what you're dealing with. So if your history is good, you would have to take a history of diabetes mellitus in this patient. You have to take a history of medication use. You have to take a history of prior polyuria. Once your history is good, it gives you an inkling clinically to what you are likely to be dealing with here. But however, if at the end of a good clinical history, the horizon still appears blurry, a simple blood glucose test and OGTT will be the differentiating factor. I know for the gynecologists of which you are, you people usually do urinalysis first to find glucose in urine, but it's important to state that the gold standard for gestational diabetes mellitus diagnosis is the oral glucose tolerance test. So I've said history will help you clinically, but if it's still blurry, please go ahead and do investigations. Thank you.
Yes, thank you, Dr. Esau. I think he has done justice to that. Dr. Collins, come on. You see, I know clinically, yes, we can attempt to differentiate this, but then blood glucose test is not expensive. So we can as well quickly do a blood glucose test, which is very easy, the easiest way to differentiate between these two. Thank you for that question. I don't think we have any other question from the chat box. Is there anyone who has a question or a contribution to give before we move on to Professor Ido, Professor Onachuku, Professor Chineye, and finally the president of the association, Professor Loco? Is there any other contribution, question or contribution, please? You can do by raising your hand.
I'm raising my hand.
Oh, please go ahead. Sorry, I didn't see the hand. Please go ahead.
Thank you, Dr. Esau, and thank you, Sasadzon, for bringing up this topic. It's a beautiful one. You've done beautifully well. I just want to pass a comment, really, just to mention that I don't know whether if we begin to maybe put up our records, we may begin to see that this condition is not really rare. And with the advent of transfemoral surgery that is going on in many of our centers, we're beginning to see cases like this. And what I want to just point out is that sometimes hypopituitarism may mask diabetes insipidus, in which we see occasionally when neurosurgery calls us to come and review. And by the time you start hormonal replacement, especially cortisol, because cortisol is also required for vasopressin release. By the time you start cortisol replacement, this patient definitely or sometimes come down with diabetes insipidus, so which could be transient or permanent. So we may definitely need to evaluate these patients afterwards to find out whether they really have transient DI or permanent DI. So that's part of the comments I want to pass.
Oh, thank you. Thank you very much, Dr. Lopade. That is very valid, a very valid point. We should be looking out for these cases. I think I'm also guilty. I think I saw one patient that had transfemoral surgery. That was some years back. I became very lazy in publishing that case. He ended up with actually diabetes insipidus as a complication of that transfemoral surgery. So these things are there. It's just that we've not really been looking for it. And then when we see it, I think we should publish, because from the presentation today, we have just two publications, just two cases have been published on diabetes insipidus in Nigeria. I think we can do better because we've been seeing more cases. Thank you very much, Dr. Lopati. Any other hand? Any other hands? Any other comments? You have the floor before we go on to our teachers in the South-South zone. We are the ones hosting. I'm sure they have something to say. Okay. I've not seen any other hand. Professor Ido, you have something to say? You have the issue. You have the floor, sir. Professor Ido, you have the floor, sir.
Yeah, thank you, Dr. Ono and Dr. Esson, for your very lucid presentation. Recently, we managed a case, a female in her 40s in the unit, and she presented with polyuria, making urine up to about 6 liters per day. And there was really no other cause for it. She was not a no DM. The blood sugar repeatedly was within the normal range. So after extensive investigation, at a point we're thinking, is it possible it could be UTI masquerading as a DI? But even despite that, she was still having this polyuria. So she was placed on oral desmopressin. And she was doing well. At a point, she had an episode of seizure. So that became a bit interesting. And when the electrolytes were repeated, she had a significant hyponatremia, which was corrected with hypertonic saline 3%. She stabilized and seems to be doing well, but she was encouraged to be taking a lot of fluids each time she takes desmopressin. She's being followed up as an outpatient right now. So just like what you said, looking at the publication in Nigeria, I know that there should be a lot more than this. Maybe we are just not writing enough. I think we should be encouraged to publish these things. Thank you.
Thank you. Oh, thank you, Prof. Thank you, Prof. Edo. Thank you very much. And I'm happy to know that at least we've seen another case, and the patient was placed on desmopressin. So desmopressin is available. It might be expensive, but it's available. Thank you very much. Prof. Unachuku, ma, are you there, ma? Prof. Unachuku, are you there, ma?
Yes.
We want to hear your beautiful voice, ma.
Hello, everyone. Can you hear me? Hello.
Yes, ma'am. We can hear you. We can hear you.
Good evening, everyone. Yeah. So, I wish to appreciate Dr. Onu and Esau for a very good presentation. Dr. Esau, it's a job well done. I know some months ago, actually, we were working on this very topic before you left Port Harcourt. So I'm not surprised you did a very good job. Very well done. Yeah, just to also, join my voice to stress the fact that diabetes is not just synonymous to diabetes mellitus, because when we are talking about diabetes mellitus, we always say diabetes. Let us always remember there's another diabetes, which is DI, diabetes insipidus. And it's actually not as rare as we always thought. We find out that many cases of polyuria, polydipsia, we always claim, we always think, diabetes mellitus. And most of them actually remain with the, private practitioners for so long before they actually present to us, maybe at the tertiary institutions. By then, most of them will even start oral anti-diabetic agents because they just believe that it must be diabetes mellitus, even when the blood glucose remains normal, despite, the fact that it is glaring at them that this is not diabetes mellitus, just because they feel that is the only form of diabetes. Also, for us to always know the essence of good history taking. You cannot make a lot of diagnosis without a good history. So you can it's always 100%. In fact, by the time you take a very poor history, you will almost always miss out DI. If you don't take a good history of trauma, history of drug injection, as per the causes, you will always miss it. Just for us to know that even this era where we think, do we really need, just go ahead and do the investigations. History taking is very important. Polyuria is not always associated, it's not always the DM. Polyuria can be from DI. A lot of other things, electrolyte imbalances can cause polyuria. Hypercalcemia is a common cause of polyuria. There are other gestational GI has been highlighted as a common cause of, it's not about pressure. We will always say, when the baby is growing, pressure on the kidneys, pressure on the ureters and bladder will cause a lot of polyuria. We have to know that DI can also occur in pregnancy as presenting with polyuria, not just the pregnancy-associated polyuria or diabetes mellitus. So I want to, urge us to create awareness that DI is actually with us. In fact, the very, very first case of DI I saw managed was in pediatric session. I had to add them, because that specialty was a little, It's a 15-year-old girl. She was already in secondary school, but had persistent enuresis. Very embarrassing to the parents. In fact, the father was is late now, used to be a medical doctor. So they were so embarrassed. And investigation revealed actually that the girl had, the cause of the enuresis was DI. Luckily, they were able to get the appropriate treatment. And the girl is is a graduate today and has done well. So for us to know that DI is with us, and we must always have it at the back of our mind that we can treat it and it's amenable to treatment. Thank you so much for asking me to comment.
Wow, wow, wow. Thank you, man. That was really, really a great one. Thank you, man. Especially that of the young lady who just shared the experience you just shared with us. It shows that yes, it can affect children. Look out for enuresis, as we mentioned, and you never can tell. It must not always be diabetes mellitus. It could actually be diabetes insipidus. And Madam has also mentioned that, remember, polyuria is not only caused by these two conditions. You can also have hypercalcemia, hypokalemia, and all of that. So thank you, ma'am, for that. I know Prof. Chineye is still on this call. I just pray he's still on this call. Prof, sir, are you still on the call, sir? We want to hear your voice, sir.
Yes. Yes.
Okay, sir.
Yes. Good evening. Thank you all. We actually, there is an ongoing West African exam, but we are having a little break. There will be examiners meeting this evening. So I'm delighted to be part of I'm delighted to really, I joined right from the beginning. And I was also impressed that I saw up to 68 participants, although gradually the number has been dropping. It's about 58 now. So it's interesting. I'm really happy that we have this platform now to keep on discussing almost on quarterly basis now. So we should keep it up. Yes. I praise Dr. Eso. Of course, I'm not surprised because he remember you sent him to our unit, and he did so well. He was very brilliant, very dedicated, and very diligent. So I'm not surprised that he did an excellent work. Yes, generally speaking, because of the burden of DM, when you use the word diabetes without qualification, generally, anywhere in the world, it is assumed that you are talking about diabetes mellitus. But that is the main thing, that is the big burden. Just like as you pointed out, DI is rare and usually not the burden. So that's why times you see most scholars, when you use the word diabetes, everybody knows that you are referring to DM. But all that notwithstanding, we have to always have a high index of suspicion. I believe that from time to time, occasionally, I think we miss some DI from time to time. Particularly, our colleagues in the family medicine side, they are the gatekeepers. So I believe that that place is a clearinghouse. So from time to time, we should have a very high index of suspicion. That first case that was even reported, just like what Professor Najuku pointed out, it was actually our colleagues in the pediatric department that first picked up that case. And then, of course, they had to draw our attention. Of course, the investigation showed that it was DI. So I believe that from time to time, we'll be encountering them. We should just keep our eyes open. In fact, the period I was in Liberia, between that 2016 up to that 2020, we reported 2 cases then. They were published in a Journal of Liberian Medical and Dental Association. Reported 2 cases. One was patient that came in from nearby Guinea-Conakry. The other one was actually a Liberian. So, yes, it is rare. But I believe that if we keep our eyes open, we will always see it from time to time. I think it was a very interesting evening, very good presentation. So I wish you all a pleasant evening and a very happy new week ahead. Thank you.
Oh, thank you, Prof. Thank you very much for squeezing out time despite a very tight schedule involved in the West African exams. I hope you will not ask them a question on diabetes insipidus. This one that is hot, is very hot now.
Well,
thank you, sir.
The EDM exam has ended.
Okay. I was just thinking, you can just throw one in and you destabilize the candidates. Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. That is why they should be joining programs like this to update themselves so that they will not take them away on our Yes, thank you, sir. Thank you, sir. Now we are rounding up now. We are rounding up. So at this juncture, we want to invite the president of the association, the Endocrine and Metabolism Society of Nigeria, Prof. Uloko, to give us the final overview, and if there's any announcement, I think this will be an opportunity to make the announcement. Prof. Uloko, you have the floor.
Okay, good evening. Dr.
Yeah, you're audible. You're audible. You're audible, Prof. You're audible.
Okay, thank you very much. Once again, I must congratulate the South Zone for hosting a very fantastic meeting, and the discussion was quite robust and rich. I must thank the able speaker, a senior resident, to have done great justice in putting this piece together. Like other colleagues have mentioned, I just to add my voice that diabetes insipidus is not as rare as we think. I have had a patient that I managed just about a year or two ago with transsphenoidal pituitary adenomectomy. I came down with diabetes insipidus, the transient one, and he did well with desmopressin nasal spray, and he is fine. So we have pockets of cases across the country and individual anecdotes of experiences. Should we take from this meeting that we should then begin to consider some form of compilation of cases managed across Nigeria? Because one of the main problems with our practice in Nigeria is that we don't document things. And this makes us look as if we are not cases. So I will challenge us that we should please think about it to do a careful compilation of cases of diabetes insipidus managed across institutions in Nigeria. It will make a good reading, and it will make a good baseline for referencing when anybody wants to do more work in the area of diabetes insipidus. I also recall managing a young lady recently with psychogenic drinking, and she did everything that you could imagine that scared the parents, and they think that she desperately needed help. Of course, she needed help, but eventually, after water deprivation test and all the assessment and evaluation, it turned out to just be psychogenic drinking, and adequate counseling and psychological support was the main treatment she needed, and that solved the problem. So again, to alert us that our efforts at getting this program on the regularly scheduled basis is on. We have a timetable that will last up to the end of the year. We request that all zones should please respect that timetable, that scheduled outline, so that notices will be placed early enough, and then people will prepare to join. This evening on this activity, at least 60 people participated in this meeting. I was following keenly. At about now to the end, we still have well over 50 people in this meeting, which is a good attendance for our number. I encourage us to continue to keep up the spirit, and then we continue to share ideas and brainstorm on endocrine-related matters. As we close this meeting, let's not forget that we are in the process of writing guidelines. And as we move from one guideline to the other, we may come to the point where we will have to cover entities like this. Well, for now, it's tough, but we know it is doable. And we are going to start with common endocrine metabolic related illnesses. I have documented guidelines that we'll be proud to identify with coming from Nigeria. And then I'm also happy that quite a number of us are making our mark on the international arena. Let's keep the flag flying. I want to thank the South-South Zone once again, and I want to thank the speaker. Thank you so very much. Good evening.
Abdullah.
Thank you. Thank you very much, able President. Thank you very much for that roundup. We've come to the end of today's presentation. And I want to thank everyone for finding time to join this meeting. And I believe we have benefited one way or the other. I want to say thank you. Happy Easter in advance. Happy Easter in advance. Thank you so much. Have a blessed week. God bless you. Bye-bye. God bless you. Bye-bye.
Bye.
Bye-bye. Thank you. God bless you. Bye, everybody.